Welcome back to the deep dive. Today we're tackling a really crucial topic, mastering health supervision in pediatric nursing.
Hmm.
Yeah, if you need to get a solid handle on the core concepts, the principles, the actual clinical practices for optimizing kids' health,
Hmm.
and you need to base strictly on your textbook chapter, well, this deep dive is definitely your shortcut.
Absolutely. Health supervision, it's really the heart of proactive pediatric care. Starts right from birth, goes all the way through adolescence, sometimes even up to 21. And it's not just about, fixing problems when they happen. It's systematic. It's about ensuring wellness. So everything we're covering today really hangs on three key pillars from the text: developmental surveillance and screening, injury and disease prevention, and health promotion. But, before we even get to those pillars, we need to talk about the foundation,
Yeah.
the system that makes it all work.
Section 1, the foundation of care. And that foundation, as you mentioned, really starts with the medical home. Now, the book defines this using those 4 C's: comprehensive, continuous, coordinated, and cost-effective. But it's not just a building, is it?
No, not at all. It's a philosophy. Think of it as a long-term relationship. And that coordination piece, oh, well, it's vital because pediatric care can get so fragmented.
Fragmented how?
Yeah.
Like seeing different specialists.
Exactly. Different specialists, maybe urgent care, school nurses, changing insurance plans. Things get missed.
Yeah.
Screenings, follow-ups, records get lost, costs go up. So the medical home idea is that one primary care team kind of orchestrates everything, builds that trust over time with the family.
Okay, that makes sense.
Yeah.
And that coordination requires partnerships, right? The book talks about a partnership triad. Who's involved?
Yeah, 3 key players. First, obviously, the child. And their involvement changes, as they get older, they participate more. So the nurse has to adapt the approach based on their developmental stage.
Okay. And second,
The family. They're the ones actually putting the plan into action day to day.
right.
So the nurse's job isn't just asking questions, it's also observing, watching those interactions.
You mentioned observing.
Mhm.
Like, what specifically? What's a quick thing a nurse could look for that gives a clue about how things are going?
Well, with an infant, it could be simple eye contact between parent and baby. Or how a parent handles a toddler's tantrum. Are they managing it effectively? For older kids, you listen, are the parents' comments supportive? Do they build the child up?
It's about finding that balance, right, between the family's own beliefs and, well, the established healthcare goals. It has to be a negotiated
A
plan.
negotiated plan, okay. And the third partner.
The community,
Mhm.
schools, churches, local health clinics, support groups. These partnerships help families overcome barriers, maybe transportation issues, financial stress. They provide those necessary resources.
And these partnerships become even more crucial with certain populations, like considering cultural influences. The text mentions the difference between a future-based outlook, common in the U.S.,
Right, where we focus on preventing problems down the road.
versus a present-based or even fatalistic view some cultures might have. How does that change the approach? It changes it significantly. If a family is focused on the present or feels like health outcomes are sort of out of their hands, a long-term prevention plan might not resonate.
So what do you do?
You shift focus. You aim for shorter-term, more immediate goals, things they can see the benefit of now. You work with their worldview to find a plan that's mutually acceptable but still moves things in a healthier direction. Less abstract prevention, more concrete risk reduction today.
Okay. Then there are children with chronic illnesses. Their visits need to be different.
Definitely. More frequent, more in-depth assessments, and a big focus shifts to psychosocial stressors.
Like what kind of stressors?
Insurance issues, transportation challenges, the financial burden on the family, how everyone's coping, how the school is supporting the child. It's a whole system check.
And the other specific group mentioned is internationally adopted children. The guidance seems very direct there.
Extremely direct. Comprehensive screening within the first few weeks of arrival, period.
Why so urgent?
Because those prior medical records, often unreliable, you just can't be sure. So you screen immediately for a whole range of infectious diseases. Hepatitis A, B, C, HIV, syphilis, TB.
Even if the child seems perfectly healthy.
Especially then. Plus, things like intestinal parasites are common. You have to assume nothing and screen thoroughly.
Got it. All right, so that sets the stage. Now let's build that first clinical wall. Component 1, developmental surveillance and screening.
Right. And the first key is understanding the difference between surveillance and screening. They aren't the same thing.
Okay, break that down for us.
So developmental surveillance is the ongoing thing. It's what skilled clinicians do over time. They note parental concerns, they get the history, they observe the child playing in the room. It's longitudinal. Continuous.
And screening.
Screening is different. It's a brief, formal assessment, usually a standardized tool like a questionnaire. Its only job is to quickly flag kids who might need more in-depth, specialized testing. It doesn't diagnose, it just flags.
That's a really helpful distinction. Okay, now, the red flags. The milestones that, if missed, are serious warning signs. What are the big ones we absolutely need to know?
Okay, crucial ones. At any age, if a child doesn't respond to environmental stimulus, sound, light, touch, that's a major concern.
Yeah.
Immediately.
Okay.
After 4 months, if there's still persistent head lag, that's a flag.
Right.
Then, hitting 15 to 18 months, if a child isn't walking or doesn't have at least one word, that needs investigation.
Walking or our first word by 18 months. Got it.
And by 3 years old, we expect 2-word sentences. Also, they shouldn't be falling frequently or having real difficulty with stairs.
And there's one alert the text really emphasizes.
Yeah.
The loss of a milestone.
Yes. This is critical. If a child could do something like sit up unsupported and now they can't, that demands an immediate, full neurological evaluation.
Why the urgency compared to just a delay?
Because losing a skill, unlike just being slow to gain one, often points to a significant, potentially progressive or degenerative neurological problem. It's a different level of concern that requires speed.
Makes sense. Now, besides watching milestones, we use risk factors. We know biological ones like low birth weight. What about key environmental risks that trigger closer surveillance?
Low parental education level is a big one cited in the text. And then there are mandated screenings, regardless of risk.
Mandated? Like what?
Autism screening has to happen at 18 months, and 24 months for all kids.
Okay, 18 and 24 months.
And for adolescents, that's ages 11 through 21, there are mandatory risk assessments for substance use and for depression.
Good to know. All right, let's move to component 2. Injury and disease prevention, starting with screening tests.
Right, and the principle behind screening tests is important. They're designed for high sensitivity, meaning they catch almost everyone with the condition.
But maybe low specificity.
Exactly, which means you might get some false positives, people who screen positive but don't actually have the condition.
Why is that trade-off acceptable?
Because the goal of screening isn't diagnosis, it's to make sure you don't miss anyone. High sensitivity ensures that. A positive screen just means, okay, now we need a more precise diagnostic test to confirm. You'd rather have a few false alarms than miss a real case, especially early on.
Okay, that clarifies things. Let's run through the required screenings. First up, metabolic screening, newborn screening.
Yeah, this is mandated by state law, though the specific number of conditions screened varies. The March of Dimes goal is pushing for like 34 core conditions. Think PSAU, sickle cell anemia.
And the key clinical point here.
Check the timing.
Yep.
Confirm the screening status at the very first visit. If that newborn screen was done before the baby was 48 hours old, it absolutely must be repeated. The results might not be accurate yet.
Okay, repeat if done before 48 hours. Next, hearing. Universal screening by 1 month old.
Yes, by 1 month. The urgency is because even mild hearing loss can really impact development, speech, language, social skills. Catching it early is crucial.
And the methods change with age, right?
They do. For newborns, we use objective tests they don't have to respond to, like AABR or OAEs. As they get older, maybe around 6 months or so developmentally, we can move to behavioral tests like visual reinforcement audiometry or VRA, where they turn their head towards a sound. Later still, conventional audiometry.
Got it. Vision screening happens at every visit, and the tools change quite a bit. Black and white patterns for infants, then maybe the tumbling E chart, then Snellen. Why the progression?
It matches their visual development. Infants under 6 months see high contrast best, not fine detail or color yet. Preschoolers might not know letters, but can point which way the E is facing. That's the tumbling E or Allen figures. By 5 or 6, they usually know their letters, so we can use the standard Snellen chart.
And the crucial technique.
Monocular testing. Test each eye separately. Cover one, test the other. It's the only way to reliably catch amblyopia or lazy eye early enough to treat it effectively.
Right, cover test. Okay, common deficiencies. Iron-deficiency anemia, the book calls it the leading nutritional deficiency. Screened around 12 months usually.
Yep, with a hemoglobin or hematocrit. Risk factors include those rapid growth spurts, like in infancy and adolescence, maybe low intake of iron or vitamin C, which helps absorption, and definitely socioeconomic factors. Kids eligible for WIC are at higher risk.
And lead poisoning. Big focus on prevention here.
Huge focus, because there's simply no safe level of lead in the blood. Prevention means teaching parents about the hazards paint in homes built before 1978 is a big one. Old plumbing, some imported canned goods, or traditional remedies.
And the text mentions a dietary tip.
Yeah, kind of interesting. A diet high in calcium, iron, and vitamin C can actually help decrease the body's absorption of lead if exposure occurs. So good nutrition is protective.
Good tip. Finally, cardiovascular screening. Hypertension checks start when?
Universal screening starts at age 3, and diagnosis isn't just one number, it's based on percentiles for the child's gender, age, and height.
Okay. And hyperlipidemia or high cholesterol?
Universal screening for that happens twice, once between ages 9 and 11, and again between 18 and 21.
And selective screening.
That's based on risk factors, primarily family history, especially if a close male relative had a heart attack or stroke before age 55, or a female relative before age 65. That triggers earlier or more frequent checks.
Okay, that covers screening tests. Still in component 2, but now moving to immunizations. Foundational stuff.
Absolutely cornerstone of prevention. Need to know the difference between passive and active immunity.
Passive is temporary, right? Like antibodies from mom via the placenta or breast milk?
Exactly. Short-term protection. Active immunity is what we're aiming for with vaccines. That's when the child's own immune system learns to fight off the disease, providing long-term, sometimes lifelong, protection, either from getting the disease naturally or, much more safely, from a vaccine.
The text lists vaccine types: live attenuated like MMR and varicella, inactivated like polio, toxoids like DTaP. But the real challenge often seems to be the management side. Documentation, for instance.
Oh, documentation has to be meticulous. It's a legal record. You need the date, the specific vaccine name, the manufacturer lot number, expiration date.
Site and route.
Site and route given, the addition date of the vaccine information statement, the VIS that you gave the parent, and your name and title. All of it, every single time.
And that VIS sheet, federal law says.
Before you give the shot, you have to give the VIS to the parent or legal guardian before administering the vaccine. Allows them time to read it, ask questions.
Okay, now, barriers. The biggest one consistently seems to be parental concerns about safety, doesn't it?
Without a doubt. Fears about side effects, sometimes specific concerns like unfounded worries about the HPV vaccine and fertility. Misinformation spreads easily.
What else gets in the way?
Sometimes just lack of knowledge about the schedule itself. Or fragmented care. If they don't have that medical home, they might miss appointments or lose track of which vaccines are due. Cost can be a barrier too, though programs exist to help.
So what can nurses do to overcome these barriers?
Well, one practical thing is using combination vaccines whenever possible, like Pediatric or Proquad. Fewer shots are always better for kids and parents.
Makes sense.
Also, really promoting and utilizing the Vaccines for Children program VFC. It provides free vaccines for eligible kids, low-income, uninsured, underinsured, Native American, or Alaska Native. Removing the cost barrier is huge.
And the trust factor.
That goes back to the medical home. Building that relationship over time allows you to have open, respectful conversations, address their specific concerns patiently, and provide accurate information. It takes time.
Okay. That wraps up component 2. Let's move to the final piece, component 3, health promotion and anticipatory guidance.
Right. So this is all about being proactive, identifying potential risks before they become problems, encouraging healthy lifestyle choices, and really empowering the child and family to take charge of their health.
And the main tool is anticipatory guidance.
Exactly. Giving them the information and skills they need before they hit that developmental stage or face that particular risk. It's education provided just in time or slightly ahead of time.
First area highlighted is oral health. The text calls dental caries the most common chronic illness in childhood.
Wow. It's a huge problem. And the solution proposed mirrors the medical home establishing a dental home.
A dental home?
Yeah, same concept. A regular ongoing relationship with a dentist starting early. The recommendation is to establish that dental home by the infant's first birthday.
By age 1. Okay. Next, promoting healthy weight and activity. Obesity rates are still high, around 18.5% mentioned. The text stresses a health-centered approach, not weight-centered. Why that distinction?
It's really important for preventing body image issues or potential eating disorders down the line. The focus should be on healthy behaviors, good nutrition, regular activity that benefit overall health, rather than just fixating on the number on the scale. It's about wellness, not just weight.
So what are some quick practical tips for anticipatory guidance around diet and activity?
Okay, for diet, Emphasize not skipping breakfast and making sure it includes some protein for sustained energy. Suggest healthy alternatives for school lunches, like freezing fruit so it's thawed and cold by lunchtime. And limit snacking to when they're actually hungry, not just out of boredom.
Good ones. And activity.
The goal is 60 minutes of moderate to vigorous activity daily for kids 6 to 17. But the key is making it fun. Non-competitive activities often work best. And encourage family participation. A family walk after dinner, playing in the park together, it models healthy behavior.
Great. Lastly, hygiene and safety.
Right.
Hand washing is obviously key. Any tricks mentioned for getting kids to do it properly?
Yeah, the classic one is teaching them to sing Twinkle, Twinkle, Little Star or the Happy Birthday song twice while washing. That ensures they're washing long enough.
Huh, I like that.
For older kids, sometimes visual aids work well, like using something like Glad germ lotion that shows where germs remain after inadequate washing makes the invisible visible. And of course, addressing hygiene changes during puberty body odor, acne is important anticipatory guidance too.
And safe sun exposure, skin cancer prevention. What's the core message?
Use sunscreen SPF 30 or higher, broad spectrum covering UVA and UVB. Apply it about 30 minutes before going outside and reapply frequently.
But there's a key difference for infants.
Yes, critical difference. Infants under 6 months should avoid direct sun exposure and sunscreen. Keep them in the shade, use protective clothing, hats. Their skin is too sensitive for sunscreen.
Under 6 months, avoid sunscreen. Got it. Any easy way to remember peak sun hours to avoid?
There's a simple rule of thumb. Play outside only when your shadow is taller than you are. That generally means avoiding the sun between about 10 a.m. and 2 p.m. when the sun is highest and strongest and your shadow is shortest.
Clever. Okay, that covers component 3. So we've really gone through the whole blueprint here, from the medical home foundation, through detailed developmental checks, all the screening tests.
Yep, metabolic, hearing, vision.
Iron, lead, cardiovascular, then the whole immunization piece, and finishing with health promotion like dental homes, healthy weight, and sun safety.
And the big takeaway really is how interconnected it all is. You need that developmental assessment, you need the injury and disease prevention strategies like screening and vaccines, and you need the health promotion piece. And none of it works effectively without that trusting partnership with the child, the family, and linking into the community resources. Those 3 components within that partnership context, that's the core of effective pediatric health supervision.
Absolutely. So as you, our listeners, think about applying this in your practice, here's something to consider. We talk about vaccine hesitancy being a major barrier. It's maybe the most challenging clinical task, sometimes navigating those parental concerns while upholding the importance of the immunization schedule. Based on everything we've discussed, the importance of trust, communication strategies, utilizing resources like VFC, what single strategy will you prioritize when you encounter a vaccine-hesitant parent? How will you start building that bridge of trust?
Something definitely worth thinking about. Thank you for joining us for this deep dive into the essentials of pediatric health supervision.